and I also record the talk. Okay, let's wait a minute that people join us, and then we start. Yeah. Okay, people are coming in large numbers. Wait until 31 and then we start. Okay, maybe I stop sharing the screen. And, okay, and I think we can start. So good morning, everyone. Welcome to this last edition for the year of our Data at Breakfast webinar series. I just need to apologize that we didn't stick to our golden rule of every last Friday in the month in November. But I thought since we won't have one on the last Friday in December, we place the last one somewhere in between. Yeah? So welcome this morning. It is a real big pleasure this morning to introduce to you our speaker, Dr. Richard Lessells. Some of you have already seen him in action in previous editions of the Data at Breakfast. He has been at UKZN, I think, working on research on HIV and TB since 2007, but he made his PhD at the London School of Hygiene and Tropical Medicine earlier. Yeah, he's a member of the UKZN COVID-19 war room and has been very heavily involved in the fight against COVID in the province and nationally. Yeah. Together with us this morning is also Professor Moza Moshabela, who some of you have also seen in action in the Data at Breakfast before. And Professor Moshabela is a public health specialist. He's also heavily engaged in the fight against COVID. And very recently, he has been appointed as DVC Research and Innovation at UKZN. So our congratulations, Moza, for this really challenging appointment in times that are not easy. Yeah. So thank you very much for being with us this morning. And Professor Moshabela agreed to moderate the question and answer session after the presentation, and he will give us also his input in this very sad resurgence of COVID cases in South Africa. And most of you have seen before Dr. Ilya Sinaisky, who is the co-host of the event and has all rights to host the event in case Eskom pulls my electricity or my internet dies. So he's our safety net. So Richard, we are ready to go. If you would like to start sharing your screen, you're most than welcome to start with your presentation. And please, participants, if you have questions, make use of the Q&A facility at the bottom of the Zoom window, and we will address the questions after the presentation. Thank you very much, Richard. You're welcome to start.
Thanks very much, Francesco. And I should first of all apologize to Francesco because he has been pestering me for a while to do this talk. And I kept trying to put it off and trying to pretend that I was busy. And now I couldn't refuse any longer. And I think that he wanted me to talk about initially whether we were going to see a resurgence or whether we were going to see a second wave. And now, sadly, as I've delayed this talk so much, we're now in a position where we're no longer in much doubt about what's happening. And I think that many of us will have that really kind of sick feeling and that feeling of dread of what is to come at the moment as we look at the numbers both in the province and nationally. So I thought that today we would just walk through a little bit of what's been happening and just trying to understand the dynamics of this virus, what has been happening with this virus and the spread nationally, and what can we learn from that, and hopefully to leave lots of time for discussion towards the end of the session. So what I want to start with is just understanding a little bit about where we are in the epidemic. And here what I'm showing you is just the standard epidemiological curve of the daily cases, so the daily new cases. So you see here the time from the beginning of the South African epidemic in March, right up until now. And here you see the number of new cases per day. And you see this pattern that we're now all quite familiar with, that we had this period where we had relatively slow growth because of the very early lockdown in South Africa. And then we had this phase of exponential growth where we reached around 12,000 or so cases every day. And then things settled down. And then we went through, when we looked at the national picture, we went through this period of a few months where we were relatively stable with the numbers, and then have recently seen this resurgence. And just in the past few days or couple of weeks, we've seen that really accelerate. Now, one way that we can help to understand what's happened is by looking at one of these numbers that you've probably all heard of and got familiar with. And this has different terms, but here we call it the RE, and it's essentially that's what's called the effective reproduction number. And I want to just explain a little bit about that, just so that it helps us to understand what's happened in the epidemic. When we talk about the virus spreading through the population, the one term that we often use is the basic reproduction number, and that's called the R0. And essentially this number is the average number of secondary cases caused by an infectious individual in a totally susceptible population. Okay, so essentially, how many people are infected by one case? And this is an average across the population. And this measure, or this metric, is dependent on three things largely. It's dependent on what's the probability of transmission if an infected and susceptible person come into contact. It's dependent on how many contacts we're each making over a period of time. And it's dependent on the duration of infectiousness of this infection. And this measure tells us the potential for this pathogen, in this case, this virus, to spread through the population. But things aren't as simple as that as epidemics mature. And what the other term is, this effective reproduction number, is this average number of secondary cases infected per infectious case in a population made up of both susceptible and non-susceptible or immune hosts. And essentially this can be estimated by simply taking the basic reproduction number and the fraction of the host population that's susceptible. So the reason that I'm explaining this to you at the beginning is because I think one of the things that we need to try to understand is what happened during this first wave or first peak, and why did that decline? Because I think that's one of the things that has confused a lot of people And I think it's one of the things that put us in a position where we really weren't sure what was going to happen and whether we were going to see a resurgence or not, because there was some confusion about why the cases had started declining in July and August. But I think that we can make some guesses of why that happened. And if we just think about the dynamics of a virus spreading through the population, you can see here that this is the period when there was exponential growth. And here, this is charting this effective reproduction number along the bottom. And you see here it was above 1 all this time, which is essentially meaning that there will be exponential growth. But what you see there is then this slope where it declines below 1 through July, essentially, from the very end of June to the beginning of August. And so what's happening there is because there was very substantial transmission of the virus and spread of the virus through the population, a large number of people are getting infected. And one thing that we must remember all the time is that our case counts are likely a very significant undercount of the true number of infections in the population. And we don't know what the true number of infections in the population is, but it's likely to be several-fold higher than the cases that we've detected and reported. So a large number of the population have become infected and are no longer susceptible. And so what happens is the virus, to some extent, starts running out of people to infect. Now, that doesn't make sense if we think of our population as just one homogeneous mass of people that are all interlinked. But we all know that we don't live in one homogeneous mass and that we're all interlinked. We live in complex social networks, some of us more complex than others. And we come into contact with different numbers of people depending on our work, our social life, and our family life. And so, and we also live quite differently geographically in South Africa. We have many high density populations. We have many much lower density rural populations. And so what we see here is that almost certainly in some of the population, we were getting enough infections that enough of the populations in those pockets of the community were no longer susceptible. And so the spread of the virus slows down as a result of that. And part of the problem that we've had with thinking about this is that this kind of thinking about how the virus will slow down as immunity builds up in the population, it got wrapped up in very political discussions globally around herd immunity. And I don't want to go into all the details of that, and many of you will be familiar and will have followed the discussions. But essentially, this got wrapped up in a discussion about whether a public health strategy was just to allow this virus free access to infect as many people as possible, in the hope that that's how you would slow down the virus, is by infecting enough people that you've got enough immune people in the population that the virus transmission slows right down. And so this got very polarized because it's very clear that as a strategy, that was not something that was acceptable to most people, because it would be associated with an extremely high number of deaths in the population. But here, what we're seeing is that you see some effect of this, and the population immunity is not an all or nothing. It's not this black or white herd immunity or no immunity. There's this scale of growing population immunity that will slow the virus transmission down. So I just wanted to try and understand that. The other thing is that confused us was that, I mean, we wondered whether this was people changing behavior and that people were better with the social distancing, the mask wearing, the hand washing and all the other behavioral interventions. But that confused us because this was, of course, a time when we were largely relaxing our restrictions and when people were coming into contact potentially with more people as we were moving down through the lockdown phases. But you must remember that we don't just change our behavior based on what we're told to do. And many of us don't change our behavior at all when we're told to do so. But we change our behavior based on the circumstances around us and based on what's happening in our close social network or that we see around us in the community. And so another possible contribution to what we saw here was that people were changing behavior because of what they were seeing happening with the exponential rise in cases, with the deaths, with the hospitals filling up. And maybe that was what allowed people to change their behavior, or that people were in some ways forced to change their behavior because of circumstances, because of being exposed to the virus and having to quarantine, or having people in the family that were affected by COVID and having restrictions on your movement as a result of that. So that's just to try and understand what happened in this first wave, because it helps us to understand where we got to later. Now, I want to just turn now to think a little bit differently and use a slightly different measure of understanding what's been going on. And here, instead of the case numbers, what I'm showing you is the number of tests performed in the solid bars and the test positivity rate. And this is by week here, running up to the last week that we have data for, which is now a couple of weeks ago. And this is just showing you the trajectory in a slightly different way as the daily test positivity rate. And the reason that I show this is because, again, we see essentially the same pictures when we look at the cases. We see this peak, then we come down off this peak and this kind of plateau. But one thing to note is that when we look nationally, we didn't really get much below 10% test positivity. And that we would consider still a high test positivity. So we didn't manage nationally to suppress the transmission much below that point. But what I want to show you is that one of the challenges we've had is when we think about the epidemic nationally, we were missing a lot of differences as to what was happening provincially. And so here I'm showing you the same thing, the test positivity, so the proportion of tests that are positive by week. But here this is showing you all the different provinces. And without going into too much detail, what I want you to just see in this graph is the different patterns, and to see that clearly things were happening slightly differently in the different provinces. So here you see in orange the Western Cape that we know was the first to really see the surge in cases in the first phase of the epidemic. And we see KZN here in blue, where our rise was later, and then we had this quite rapid decline in cases. What you see here with some of these smaller provinces is these provinces have still been declining right up till now when you look at the test positivity. So while we see this resurgence in the 4 main provinces, we're still seeing that in the 5 smaller provinces, they're still in many ways coming off this first wave of the epidemic and coming down from that first wave of the epidemic. And one thing we need to really think about at the moment is how we protect those provinces from the resurgence that we're now seeing in the bigger provinces. This is just showing you the 4 main provinces, and this is the same graph I showed you of the national data, showing you the tests performed and the test positivity. And so the curve that you're seeing is the same as you've just seen with all 9 provinces together. And I find this a useful metric because it kind of accounts for different testing numbers, and it's just a slightly cleaner metric than looking at the cases, because the cases, you don't know how much testing is happening, and so the test positivity can be a useful metric alongside looking at the cases. And what struck me recently looking at this and looking at what was happening in the Eastern Cape and the Western Cape was just how similar the slope of the increase was. So if we look at the Eastern Cape, if you see this slope in the first phase of the epidemic, it's essentially very similar to what we've seen over the last couple of months there, this very rapid rise. And when you look at the Western Cape, you can see, just notice that the slope is slightly less steep. But again, in the last few weeks, it seems to be following much the same pattern. And that's really a warning for us in KZN, because if you look at KZN, we know we had this very steep rise. And so the worry is that if we follow what's happened in the other provinces, then we're going to again see this very steep rise in the test positivity and the cases in the province. So just coming back, the point that I'm trying to make here is that as we've kind of looked at the national numbers and kept an eye on the national numbers, and we all pay close attention to the numbers that are produced on a daily basis. If we just think about things nationally, then we miss a lot of the nuances that are happening at provincial level, and of course, even at finer level than that, so at district or sub-district level. And so again, if we just think about that a little bit, I'm showing you the Eastern Cape here, the tests performed in the purple and the test positivity rate. And what I want to show you here is that although we came off this peak in the Eastern Cape, you can see actually there was not much of a plateau there if we think about the test positivity. Again, it didn't get much below 10%. And once it got there, it then started rising again. And although that rise was initially quite gradual, it then was only a few weeks until it really accelerated. And we saw this really accelerated growth in the Eastern Cape. And one thing, as I say, is to think about this on finer scale. And here what I'm showing you is just some geospatial data to show at kind of sub-district level what's happened over the past few weeks in the Eastern Cape. So here, this is showing you the test positivity again, as a proportion. And the darker the red color, the higher the test positivity. And the very dark red coloring is when more than 30% of the tests are positive. So basically, more than 1 in 3 of your tests are positive in that area. And the lighter green and yellow is much lower test positivity rates. And this is just showing you the 4 last weeks of data, and essentially this is the 4 weeks of November. So we're a little bit behind where we currently sit. But really the point to take here is just the very rapid spread through the province of the virus, if we take test positivity as a good marker of what's happening and how the virus is spreading. So you can see that although things were initially focused around Nelson Mandela Bay, actually very rapidly it spread to the other districts in the province. And by the end of November, you see test positivity above 30% in large sections of the province. So really very substantial penetration of this virus through the population in the Eastern Cape again. And not surprisingly, that's been associated with the really catastrophic situation in terms of the hospital admissions, the strain that's been put on the hospitals there, both the public and the private sector, and the huge number of deaths that we've seen again through this resurgence in the Eastern Cape. This is the data from the MRC that looks at the excess deaths. So again, this is showing you the kind of overall toll of the epidemic in terms of the deaths. We don't know for sure what proportion of these excess deaths are COVID deaths and what proportion may be deaths due to other causes. But it's likely that the majority of these are COVID deaths. And here you see Nelson Mandela Bay at the bottom, where the deaths rose to a higher level than in the first phase of the epidemic. So really very, very substantial mortality associated with the resurgence in the Eastern Cape. Just looking at the Western Cape, again, the thing that was highlighted was that the areas that seemed to be affected first by the resurgence in the Western Cape were the areas closest to the Eastern Cape border. And it was the garden route areas. And here you see these in red. But again, if you just look at the weeks in November, you can see that very quickly the virus moved beyond that localized area, and you start to see other parts of the province with these very high test positivity rates, above 30%. So, time to focus on KZN and our own province, and just think about where we are at the moment. We had this quite long period of plateau, where again the numbers were relatively low, in the few hundreds. But we know now in the last few days, the last week or so, that we're now seeing a very rapid growth again in the numbers. And if we look at what the estimated R value is now for KZN, it's sitting somewhere around 1.6. which is worryingly high. And I say worryingly high because just to illustrate that again, that means for every 100 people infected, they will infect 160 people, and then that will continue to rise exponentially from there. And it also means that to get this below 1 again, we're going to need quite substantial public health interventions. This is not something that a small tweak will get the R value below 1. This is going to need concerted effort to get the R below 1 and to start contracting the epidemic again. This is KZN showing the test positivity and the tests performed again, just showing again that in KZN, we did see that the test positivity got actually below 5%, which is quite good. So we had an opportunity then to really get control of the epidemic, but we didn't get it really much below 5%, and we saw then this kind of more plateau over October and into November, and then we started to see this rise, and we're going to now see, as I say, that rise is going to be much steeper, I think, over the next few weeks. Again, this is just showing you the geospatial aspect in KZN, and you see the coloring different from the other provinces because we've had this later resurgence again. But I just want to highlight that as you go through the weeks here, you see the areas that are starting to show higher test positivity are again the areas bordering the Eastern Cape. And particularly here in red is the area around Kokstad, where we know there's quite a lot of movement of people across from the Eastern Cape for healthcare and for other reasons. And so what I've been trying to kind of illustrate here is that what we're seeing again is these different phases of the epidemics in the different provinces. But I think there's a picture building that the resurgence in the Eastern Cape was spreading much more widely than we were recognizing, and has then spread both to the Western Cape and to KwaZulu-Natal. And that shouldn't surprise us really, because the movement is unrestricted at the moment in terms of cross-provincial travel and cross-district travel. And we know that we have a very mobile population. And we also know that as the healthcare system in the Eastern Cape becomes more and more overwhelmed, then people also seek healthcare in the other provinces. And we see that here in Durban, we see it in these southern parts of the province. And so that can contribute to then the spread of the virus through the other provinces. So I wanted to finish up just by thinking, if what I'm saying is true, that we're now at a level where in KZN we're going to see very rapid growth of the epidemic again, and we have this very high R value around 1.6, then we have to think again, what are the public health interventions that we can introduce? And again, my feeling here, and I hope that we have plenty time to discuss this, my feeling again is that we've become, or we have been far too polarized again in thinking of the interventions, and that we've broken it down far too simply into, are we going to a hard lockdown or not? And again, the idea of a hard lockdown has got so emotive, and the feeling is that there's no chance that we can go to another hard lockdown. And so we consider that that's the only intervention we can do. But of course, that's not the only intervention we can do. That's one extreme of the interventions that we introduce. And it's quite right that should only ever be a last gasp measure. It's an admission of failure, essentially, an admission that you can't control the growth of the epidemic by other means. And I think it's acknowledged by many people that the lockdown in our context has very significant adverse consequences. But we have to think of ways that we can reduce this R value and control the spread of the virus in the population. So when we think about reducing that, we have to think, what do we do to get this R value lower? So when we think about the effective reproduction number, well, the first thing we can influence is the fraction of the population that is susceptible. And of course, we know that the way out of this epidemic, the only real way we're getting out of this epidemic, is through vaccination. And by vaccination, we reduce the fraction of the host population that's susceptible. But we know, although it's incredible that the vaccine is now being rolled out in the UK and soon many other countries, and many other vaccines are going to come online, this is not going to help us in the next few months as we face this resurgence in infections. It's likely that it's going to take some time before we get vaccine here in South Africa. And it will take even longer to get the levels of vaccination coverage up in the country to really influence the spread of the virus and the spread through the population. So if we have to wait for that, then essentially we can address the determinants of the R0, the basic reproduction number. And that just means that we have to address one or other of these determinants. So we have to reduce the probability of transmission if an infected and a susceptible individual come into contact. And these are the key public health interventions, behavioral interventions that we are promoting at the moment and trying to encourage. For some reason, sorry, it wasn't meant to come up. I don't know what happened to my icons. So essentially, to do that is what we're all being told now to focus on. And that's the mask wearing. It's the physical distancing, keeping separate from other individuals. It's good ventilation when we're in indoor spaces. It's the hand hygiene. And it's avoiding the large crowds and the enclosed spaces. So it's all those measures that we know we should be doing and we're being told repeatedly to do. But unfortunately, not enough of us are doing to have a significant impact on the epidemic. This marker, the duration of infectiousness, unfortunately, we can't really influence at the moment. We haven't developed any therapeutics that influence the duration of infectiousness. And so here, we're a bit stuck at the moment. So we're left here with contacts per unit time. And I think that clearly what we need to do is we need to all be reducing the number of contacts that we're making in our life. And one of the concerns is that, again, when we talk about our public health interventions, we talk about social distancing, and it's a very mechanical term and a very term that comes really from modeling, and you hear us talk a lot about non-pharmaceutical interventions, which is a really dreadful term, and it's the language of mathematical modelers and epidemiologists, but it doesn't translate well to trying to influence people's behavior, I think. And one of the things we need to really think about is why is the communication really not working, and why are we not able to influence people's behavior in the way that we would like to? Because unless we understand that very rapidly, I think just continuing with the same strategy is not likely to yield the results that we wanted to. And I think particularly the kind of sense of scaring people and blaming people, I do worry about that as a strategy. And particularly when it comes to what we've seen over the past couple of weeks with the infections in the young people, I fear that we're going to see a lot of blame being placed on the young people for fueling this resurgence in the epidemic. And I think what we've seen around the world is, again, that's not a very good public health strategy to start blaming people and stigmatizing people even more. We have to really engage and try and understand how we can influence people's behavior. And we have to move very quickly. And I want to finish, and I hope that this plays adequately and that you can hear the sound on this. I want to play you this video, and this video is of a gentleman called Mike Ryan, who many of you will have heard. He's one of the main people in charge of the response at the World Health Organization. And he, along with the director and with another leader, Maria van Kerkhove, they're the ones that give the kind of regular press conferences. I think now it's twice a week that they give press conferences to update people about what's happening with the epidemic. And they're really important to listen to, because these are people trying to help countries across the world with their responses. And they're people with vast experience. And when I wonder about what we're doing, and I wonder about where we're going with the epidemic, I regularly come back to this video because it's very striking to me. And it's very a clear reminder how dangerous this virus is, how transmissible it is, and how rapidly it will spread through the population. And how, if we want to respond to it, we have to move very, very, very quickly. And we have to make decisions without fear of making wrong decisions. And so I'm just going to play this to you. And as I say, I hope the sound you can hear.
Richard, I fear we can't hear the sound.
Oh, you can't?
No.
Okay, that's not going to be very effective then. Okay. I can hear it, so I don't know how I project it. I should have thought about that more before adding that. Okay.
We can share it, Richard. Yeah.
Say again?
We can share it. That's what I was thinking.
Okay, yeah, we'll share it. I mean, essentially, to just summarize, is essentially what he's saying here, very, very passionately, is that you have to move with great speed if you're going to respond to this virus, and you have to act without fear of making mistakes, and you have to act when you don't know the exact situation you're in, and you don't know exactly what to do, but you have to make decisions, and you have to take the community with you, and you have to keep a clear and consistent message. And I think that we're back in a situation where that's a very important message, that if we're going to respond to this resurgence in the epidemic, we need to again move very quickly without fear of making decisions that are unpalatable or that may turn out to not be the perfect decision, but they have to be made. So I'm going to finish up there and hand over to Mosa.
Thank you so much, Richard, for that. Always enlightening. We're gonna do a marathon through the questions with the discussion with you for the next 14 minutes. But really, this I think are pertinent questions. I think overall, colleagues who are listening are trying to, one, come to grips with understanding the pandemic. There's a lot that is happening. There's a lot of information, and there's a lot of uncertainty, as you say, but decisions still have to be made. But at the same time, there's also concern about, what do we do as a collective to try and intervene and prevent this kind of having extreme harm. The last part really generally is about people trying to, figure out what they should do individually. And as you say, it becomes difficult to translate what we are seeing broadly and make sense of it at an individual level generally. But maybe let's start with this issue of susceptibility. The pertinent question there is, if people have been infected, they have immunity, then how do we talk about susceptibility when we know that there's still a risk of reinfection? How do you then make sense of that?
Yes, and that's one of the challenges that we have, is that we still, we obviously know a lot more now about immunity than we did a few months ago, but we still don't have a clear understanding of how long lasting the immunity is going to be. There's kind of increasing data that there's probably reasonable protection for at least 6 months, but we don't really know beyond that. And of course, we're now in a situation where we're several months out from that first peak. And I think that it's very difficult, especially here, to get a handle on whether we're seeing reinfections. There's certainly increasing talk amongst clinicians on the ground that they're seeing many cases of suspected reinfection. But actually being able to prove that is very challenging.
Yeah. So one then might assume that if someone was infected, say in March, April, they could still be susceptible at this point. So you can be a case in the first peak or first surge, and then be another case in the second surge.
Yeah, absolutely. And I think that we have to essentially, this sounds strange, but we have to think about our behavior in a way that we think that we are all susceptible and we are all potentially infectious. And if we think about our behavior in that way, of course, in that way, we would just isolate ourselves completely and never leave our room, which is impractical.
Yeah, exactly.
But not going to that extreme, we need to think in that way, that we're both susceptible and we're both potentially infectious. And so our responsibility is in two ways: to avoid passing on the infection if we have it, or to avoid acquiring it and then passing it on.
Okay, it kind of goes against our kind of human nature to think ourselves as susceptible. I mean, we want to think that it's not going to come to me, it's not going to get me, so until it does. So, but I think that having to think of yourself as someone who's susceptible, it's quite humbling. Okay, let me go to the next point, and this one is about the fact that when you're presenting excess deaths, in a way, they are a marker of the peaks, and I'll come about positivity rate just now. They are a marker of what's happening with the pandemic. And the example you showed of Nelson Mandela Bay shows that it looks like there's a trend that the second peak that we are seeing for Nelson Mandela Bay is starting to come down. And is that an indication? Should we raise our hopes that Nelson Mandela Bay has kind of gone over the second peak?
I think that there are certainly some positive signs in that sense from Nelson Mandela Bay. I think there's evidence that the hospitalizations have started to slow down again. And as you say, the deaths may be coming down again. We need to be wary with even the excess deaths that, of course, these still require reporting of the death. And we know when an area like that is so overwhelmed by the epidemic, there may, of course, be increasing gaps in the reporting of deaths. So it's difficult to tell at the moment, but I think it's quite likely that they are in a situation where, again, because there's been this very rapid spread through a relatively limited population, the epidemic is slowing again there and will slow. But again, we need to learn from what happened this time to understand that as things slow, if we just leave things to happen naturally, then of course there may be again a resurgence. And that's where it comes to your point of the people infected in the first wave may be susceptible again in a third wave or a subsequent.
So now, can you clarify again the difference between, when we talk about excess deaths, the difference between attribution to COVID-19 and to non-COVID, just briefly?
So I think that's something that there's a lot of work going on, is to understand what proportion of those excess deaths are COVID deaths that have not been either detected or reported in our reporting systems. And that's going to take a bit of time to understand. And that's the case around the world, that when people look at these excess deaths, it takes time for you to understand how many of those are COVID deaths. I think one concern that certainly I have and others may share is that as these parts of the country are hit so badly in these recurring phases of the epidemic, of course, we really worry that each time there's then an increasing impact on the other health conditions, the chronic health conditions, whether that's HIV, diabetes, hypertension, and that we may not have seen many excess deaths from these other conditions in that first wave, but as we continue, I'm certainly worried we're going to see more of a contribution from these other health problems.
So like you have an immediate kind of immediate consequences or immediate collateral damage, and then you've got sort of a delayed consequence or delayed collateral damage.
Yeah, I mean, we can, if we think about that in HIV, that's the kind of easiest to think about, is that if we have interruptions to our healthcare and interruptions to our antiretrovirals, that doesn't lead to an immediate kind of death. Usually, that takes time then for people to lose control of their HIV, the suppression, and then to develop opportunistic infections, and so the death comes much further down the line, and so that's another huge challenge for us at the moment.
So let's turn to positivity rate, because and it's not just today. Repeatedly, you have been really kind of getting people to focus on positivity rate and pay attention to it. But as a metric, you know, colleagues are asking, you know, a few questions about it. I'm concerned a little bit about it. One is that, what are those things that limit the accuracy of the positivity rate? And you know, Andy was asking a question about, is that not really affected by access to testing?
Yeah, I should have probably highlighted that all of our metrics have limitations and slightly different limitations, and the test positivity rate certainly has to be interpreted still in light of these limitations. Like you say, it depends on the testing strategy still. Who are you testing? And we know that in different phases of the epidemic, different provinces were doing slightly different things. The Western Cape moved quite early to just testing hospitalized people and the high risk, the elderly, and things. So there have been different testing strategies. One of the things I meant to highlight was that kind of when we came out of that first phase and we're in that plateau, there was a very sensible shift in the guidance around testing and the testing strategy, and there was a push to expand the testing, to be more proactive with testing contacts, whether they were symptomatic or not. But I think we saw that actually putting that into practice may have been very challenging, and we didn't have enough of a window, enough of a breathing space to really get that strategy going and to increase testing. And what we've seen around the world is that it's perversely, it's that period as you come out of a wave or whatever, that's when you need to really expand your testing. You need to then be much more proactive, make sure you're getting the contacts traced, tested, because that's how you drive the transmission down. But as I say, our systems were overwhelmed. Our healthcare workers were stretched beyond belief, and we haven't had a breathing space to really get that into action.
So have there been, I mean, during the first wave, there was clearly testing capacity. Have there been any reports, concerns now? Is there something that we should worry about?
Sorry, Mosa, you're.
Oh, sorry. It's access to testing. Have there been any challenges with testing, be it reagents or capacity and so forth, so far?
My understanding is that the reagents issue is not such an issue now, that the supply of reagents is more stable. I think what we've seen is what we expected, that in the Eastern Cape, as the systems got overwhelmed, then the testing systems got overwhelmed at the same time. But there are contingency plans there for other provinces to help out. And I know that the lab here in KZN has been helping with the Eastern Cape testing. And so there's much kind of stronger systems in place to share the load, if you like. There's obviously also the introduction of the antigen testing. And I haven't seen much data on that to understand how that's going and how much that's contributing in the Eastern Cape. And I hope that we see some data so that the other provinces can learn from that and see how we can best apply that.
Yeah, and you have shown a lot of interest in this and why it's sort of a promising intervention.
The antigen testing.
Yeah.
I think the antigen testing could have useful role here. I think, again, it may have been most useful in this period when we were trying to really suppress transmission and trying to prevent another surge in cases. And there, I think the utility is kind of in situations where you've got clusters or outbreaks, and you want to kind of rapidly test a group of people, then the antigen testing can be useful. I think globally, what people are really thinking about the antigen testing for is the kind of frequent mass testing, and there's increasing data coming out from places like Slovakia, where they mass tested half the population, or more than half of the population, and interesting data that seems to show that had a very substantial effect on the epidemic, although there were other interventions happening at the same time. But these kind of things, in our context, very challenging to deliver that kind of mass testing approach.
Yeah. So, I mean, we're coming to the end of our time, and we have come there already, actually. But I just want to bring up this issue of age distribution. I mean, throughout this pandemic, we've talked about age, and in many different ways. And now we are seeing a situation where, with this new set of infections, there's a peak of infections among the youth. And of course, as you said, rightly said, that it then leads to people blaming the youth and all of these things that are not really conducive for our pandemic response. But can you just a quick summary of what this age distribution, how is it playing out in terms of linking it to risk and risk assessment, and the way that, as people, we are constantly assessing risk, constantly. And we make decisions because we are constantly assessing risk. Can you just give a brief overview of this role of age distribution and risk assessment, and maybe finish off with how we should be approaching it?
Yeah, I mean, I think that you would do a much better job of answering that question than me, almost certainly. I mean, I think that it's thinking about that again, even if we think about the age distribution, these are not isolated groups of the population. So the young people, they may primarily mix with other young people, but our concern is the mixing of the age groups. and you and I both know that our big concern over the past few weeks and months has been thinking about the university students and thinking about that time when people go home for the holidays, and that potential, if there is a lot of spread in the younger people, to then spill over into the older populations. And I think we have to follow what we've seen elsewhere around the world. And although our society and population is not the same as European countries, but the principles are the same, that what they saw was the kind of second wave was initially amongst young people, and that fed into the complacency that they weren't seeing so many deaths, and so this was not significant and we shouldn't worry about it, that this was just a rise in cases, but you weren't seeing the hospitalizations and the deaths, and there was that false sense of security, that actually it's no harm if a lot of young people are getting infected. But of course that changed, and because of how society is structured, that did then start to get into the older population, and then we saw the hospitalizations and the deaths again. So I think that although there may be differences here, broadly the concerns are the same, that protecting the vulnerable, the elderly and the vulnerable is a very difficult strategy, and whilst we need to think about what we can do, protecting them in some isolated ways is extremely difficult. But I
so
in your thoughts.
Yeah, no, that's good. I mean, I'm happy with that. I think that yeah, we're still grappling very much with how we individually position ourselves, and the uncertainty of what's coming is really a big threat. We want to understand, but also at the same time, we are very much aware that we are at risk and people amongst us are also at risk. So maybe, do you have any thoughts on what we should be expecting, what we can expect in the next few weeks over the festive season until we reconvene again in January and start to reassess what would have happened in retrospect, but just some foresight on what we should expect and how we should be positioning ourselves in relation to your predictions or forecasts?
I mean, I think the virus is showing us that it's going to do what it did. We're going to see very rapid growth of the epidemic again, and I think it's clear that the virus is not finding any particular challenge in finding new people to infect at the moment, and unless we change that substantially, we're going to face a very similar situation to what we faced in July. I don't see any glimmer of hope that things would be different, and I think one thing we didn't touch on is that one of the hopes we had that hasn't come to true was we hoped that the seasonality effect would kick in early on, and certainly I had some hope that we might not see resurgence until the winter, but again, what's clear is any seasonality of this virus is going to kick in much later down the line, and the temperature and humidity may have an effect, but doesn't override people being in close proximity. So if we are in close proximity to other people, then transmission will occur regardless of the temperature and humidity. So we can't be reassured by anything around that.
Thank you so much, Richard, for your insights. As always, there's still a few more and very interesting questions that colleagues have raised. And maybe, Francisco, if it's possible for Richard to send written responses to some of them, then it'll be wonderful if we can do that. But thank you also, Francisco and Ilya, for the opportunity. And I want to take this moment to wish everyone a safe and healthy, restful festive season. And if people can, stay put and not necessarily engage in a lot of movement and limit the spread, it would really go a long way. Any contribution from any individual person would be most appreciated. And really want to, as much as possible, limit the impact on the healthcare system, on the healthcare workers, on hospitalizations, and on deaths as much as possible. So thank you so much for the opportunity to engage here. And Richard, as usual, great conversation. And we could have gone on for another hour, back and forth. But over to you, Francisco. Thank you so much.
Yeah, thank you very much, Richard, and thank you very much, Moza, for your comments, and Richard, of course, for the very informative talk. And of course, we will pick up the suggestion of Moza, and we'll be back in January to discuss what happened over the festive season. Yeah, but in the meantime, I think we all got the message very clearly that it's up to us individually to act responsibly and go in our small surroundings, whatever we can to make it difficult for the virus to jump from one person to the other. I would now also briefly like to thank the people that make the data breakfast possible behind the scenes. Yeah, those that you sometimes see, but not very often. Yeah, first of all, Ilya, who the whole year acted as backup plan and co-host, because unfortunately sometimes we can't trust ESCOM, sometimes the internet comes and goes, and he's just the plan B in case something happens. Yeah? But I would also like to thank Kimara Naikar, who is a PhD student in my group, who takes over all the invitations business, yeah, and is in contact with you, sending you the adverts, and also other people like Neliziv and Kube, who is then the link between Kimara and the university, yeah, to spread the adverts, not the virus. Yeah. So thank you very much to all of them as well. And of course, a last thank you to Richard and Mose for the precious time this morning. I know that both of you are heavily involved in the fight against COVID. So we really appreciate your time and your effort to be with us this morning. Yeah. So, and to all the participants, all the best for the festive season. Stay healthy and safe, and we will see you back in January. So thank you very much, everyone. Have a good day. Yeah. Thank you. Thank you very much.
Thank you.
Bye. All the best.
Thank you. Bye-bye.
Bye.